Today, we are talking about something absolutely foundational in stroke rehabilitation, which is Brunnstrom's stages of motor recovery, specifically how we use it to grade voluntary control in patients with hemiplegia. By the end of this video, you'll know what the 7 Brunnstrom stages mean, how to assess voluntary control in both the upper and lower limbs, and how this helps us plan physiotherapy. So, let's get into it. Hey everyone, welcome back to the channel, or if you are new here, a very warm welcome. I am Amita, a physiotherapist, and this channel is dedicated to making physiotherapy concepts easy to understand, whether you are a student, a clinician, or someone caring for a family member after a stroke. Then, why do we need a grading system? When a patient has a stroke, the damage to the brain disrupts the normal pathways that control the movement. What we see clinically is a very specific and predictable sequence of motor recovery. Now, this is important. Recovery doesn't happen randomly. It follows a pattern. And Signe Brunnstrom, a Swedish physiotherapist, studied this pattern in the 1960s and gave us a 7-stage framework to describe it. But why does this matter to us as physiotherapists? Because once we know which stage a patient is in, we can set realistic goals, choose the right treatment techniques, monitor progress over time, and communicate clearly with other healthcare professionals. So think of it like a map. Without it, you are guessing. With it, you know exactly where your patient is and where they are headed. Let's go through all the 7 stages first as an overview, and then we'll break each one down. So stage 1 is flaccidity. In this, there is no movement at all. The muscles are completely limp. This is usually right after the stroke, so which we call the flaccid stage. And stage 2 is associated reactions or minimal voluntary movement. The patient can't yet move on command, but you start to see associated reactions where movement in one limb triggers an involuntary response in the affected limb. Spasticity begins to develop. There may be very minimal voluntary movement, but it's not reliable. Stage 3 is voluntary movement in full synergy pattern. Now, the patient can move voluntarily, but only in a stereotyped fixed pattern which is called as synergy. Spasticity peaks here. The patient cannot isolate individual joints, so movement is all or nothing in a set pattern. Next is stage 4, which is movement outside the synergy begins. So some movement combination that break out the fixed synergy pattern are now possible. Spasticity starts to decline. This is a big milestone. Stage 5 is more difficult out of synergy movement. So the patient can now perform more complex combination. The synergy patterns lose their grip, so spasticity continues to decrease. Stage 6 is near to normal isolated movement. So individual joint movement is now possible, coordination approaches normal, and spasticity has essentially disappeared. Stage 7 is the normal motor function. So there is full recovery. Normal movement, coordination and speed is achieved. Before we go deeper, I need to explain synergies. So you might have listened it when I was explaining about stage 3, where synergy is a stereotyped fixed pattern, that one. In a healthy brain, movements are flexible and adaptable. After a stroke, voluntary movement is hijacked by abnormal rigid mass patterns, which are called as synergies. So the patient cannot move one joint without all the other joints in the pattern moving together. Here, there are two main synergy patterns. One is flexion synergy and another one is extension synergy. So as you can see here, in upper limb, the flexion synergy includes scapular retraction and elevation, shoulder abduction and external rotation, elbow flexion, forearm supination, and wrist and finger flexion. And under extension synergy, this includes scapular protraction, shoulder adduction and internal rotation, elbow extension, forearm pronation, and wrist and finger flexion. So as you can notice here, wrist and finger flexion both stays in flexion in flexion synergy and as well as in extension synergy. And now we'll move on to lower limb. So in lower limb, flexion synergy includes hip flexion, abduction, external rotation, knee flexion, ankle dorsiflexion and inversion, and toe dorsiflexion. Under lower limb, extension synergy, hip extension, adduction, internal rotation, then knee extension, ankle plantar flexion and inversion, and toe plantar flexion. comes into the picture. So here you can see the images which explains about the synergies, both flexion and extension pattern. The reason these patterns are there, they are clinically important. They are the foundation of abnormal posture, spasticity and gait deviations in stroke patients. So our entire physiotherapy treatment approach in the stages is about breaking these synergies. Now let's go stage by stage and talk about how you actually assess voluntary control. So what movements you ask the patient to do and what you're looking for. In upper limb assessment stage 3, the patient can move but only within a full synergy pattern. So for the upper limb, under flexion synergy, ask the patient to scratch behind their ear. If they can do it only by using the full flexor pattern like shoulder abducting, elbow flexing, they are in stage 3. And for extension synergy, ask them to touch between their knees with their hand while the knees are held together. This pulls them into the extensor pattern. You can see here in the videos about flexion bias and extension bias. And for the stage 4 is when the movements start to break out of synergy. The tests are for A4A, can the patient place the hand behind their back? This requires shoulder internal rotation combined with elbow extension, so which is against the normal flexor pattern. And for 4B, can they raise the arm to a forward horizontal position, which requires shoulder flexion to 90 degree. And for 4C, can they perform pronation and supination with elbow bent at 90 degree? So if they can do this even with some effort or limited range, they are at stage 4. In these videos, you can see how 4A, 4B and 4C tests are being taken. And for stage 5, this involves more demanding anti-synergy combinations like raising the arm to a side horizontal position which requires shoulder abduction to 90 degree with elbow extended, and for 5B, raising the arm forward and overhead which requires shoulder flexion past 90 degree, and for 5C, which requires pronation and supination with elbow fully extended. So as you can see in this video, how 5A, 5B and 5C tests are being taken. Stage 6 assessment involves speed test for upper limb. So this tests the coordination and precision of individual joint movements. If the patient can do this smoothly and spasticity has essentially gone, they are at stage 6. In lower limb assessment for stage 3, ask the patient to perform hip, knee, ankle flexion both in lying and in standing. If they can do it but only in the full synergy pattern, they are at stage 3. For stage 4, under sitting, so can the patient flex the knee beyond 90 degree with foot sliding backward on the floor? This makes sure they break the extensor synergy. And for standing, can they dorsiflex the ankle voluntarily without lifting the foot off the floor? This makes sure they are at stage 4. And in stage 5, for the lower limb, in standing, can the patient perform knee flexion without hip being flexed? That means isolated knee flexion while the hip stays in extension or near extension. This is hard because it goes completely against the flexor synergy. And in standing, can they dorsiflex the ankle while the knee is extended? Again, this breaks the extensor synergy. In stage 6, for the lower limb, this test includes standing and sitting. Under standing, hip abduction beyond what pelvis elevation alone would achieve, and in sitting, reciprocal action of the inner and outer hamstrings combined with inversion and eversion of the foot. So if the patient can do this smoothly and spasticity has essentially gone, they are at stage 6. And that's Brunnstrom's voluntary control grading. To summarize, there are 7 stages from flaccidity to normal. Recovery follows a predictable path through synergy dominated to synergy free movement. You assess each stage using specific standardized movement tests for both upper and lower limbs. The stages directly guide your treatment planning. If this helped you, please give it a thumbs up. It genuinely helps this channel grow and reach more physio students and clinicians. Drop your questions in the comments below. I'll read every single one. And subscribe if you want more content like this. See you there.